Hello everyone, thank you for joining us for the Kirby Institute seminar series today. My name is Andrew Grulich and I'm the head of the HIV Epidemiology and Prevention program here at the Kirby. I'd like to begin today by acknowledging the traditional custodians of the lands which we gather today and pay my respects to their elders past, present and emerging. And I'm talking to you today from the lands of the Bedigal people of the Eora Nation. And I'd like to extend my respects to any Aboriginal and Torres Strait Islander peoples who may be joining us today. A little bit of housekeeping to start with for today's presentation. So today we have two presenters followed by a Q&A at the end. So we'll have about two roughly 20-minute presentations and then plenty of time for, I hope, an active and engaging Q&A at the end. So your questions are really welcome. So to ask a question, please click on the icon with the speech bubble and question mark in the top right-hand corner to open the chat panel. When you click on ask a question, please do remember to write your name, and that will help us reference your question and make answering easier. So with that, we'll move straight into today's presentation, and our first presenter is Phillip Keen. Phillip is the coordinator of the New South Wales HIV Prevention Partnership Project based at the Kirby Institute. The project began as an NHMRC Partnership Project in 2015 and has been extended with new funding from the New South Wales Ministry of Health. Phillip is also a PhD candidate at the Kirby Institute. Please welcome Phillip Keen.
Thank you very much, Andrew. I'd also like to acknowledge the traditional owners of the land I'm on, which, like Andrew, is the Bedigal people of the Eora Nation. And I'd also like to pay my respects to their elders past, present and emerging, and acknowledge that this land was never ceded. So thanks everyone for joining today. I'm going to be presenting before Cherie, and effectively what I'm presenting is some data that we produced in the project that Andrew mentioned, the New South Wales HIV Prevention Partnership Project, which for brevity I'll refer to as the NHMRC. And so what we did some analyses in 2019, which we then used in 2020 in conjunction with the ministry to help inform the consultations for the HIV strategy, and Cherie will then be talking about how those reflected the priorities in the new strategy. So a little overview, I'll be talking a little bit about the partnership project, then presenting some data that we think are really interesting about the population of gay men in New South Wales, then some data from that analysis I mentioned that we did in 2019-2020, looking at trends basically over most of the period of the second HIV strategy. And then related to that, trends in notifications, HIV notifications over the same period, and a little bit on research in stigma, which also helped inform the strategy. So New South Wales has had HIV strategies since 2012. The new one just released is now the third HIV strategy. So the NHMRC was established. It was Andrew submitted the funding to the NHMRC, the application in 2014, and the project began in 2015. So one thing we did right at the beginning was helped with a little bit towards the development of the second HIV strategy in 2016 to 2020 by doing some reviews of evidence that was relevant to that strategy. But one thing I wanted to point out is that in New South Wales, as many people would know, the greatest burden of HIV infections are among gay and bisexual men, or who are referred to in HIV surveillance data as MSM, men who have sex with men. So the project was established effectively to do monitoring and evaluation of the New South Wales HIV strategies. We also undertook a number of separate projects in relation to behavioural surveillance, behaviour of gay and bisexual men. The principal partners, just because of that that burden of HIV diagnosis among gay and bisexual men, the principal focus of the project is on prevention among gay and bisexual men. So not all population groups, but the Kirby Institute and the Ministry of Health are the principal partners, or were the principal partners in that project, and ACON Positive Life New South Wales were the community partners. The Centre for Social Research in Health at UNSW, another research partner, and ASHM was the last partner. And one thing we did in the project was we established a number of working groups in relation to PrEP, treatment, HIV testing and behaviour, and those met quarterly to review monitoring data. We also had a steering committee that met quarterly, and through those processes what we effectively established was a very, we think, a method for very rapidly translating research results into policy and implementation practice. And there were a number of changes in policy and practice that happened over the course of the second strategy that were a direct result of findings from this project. So moving on now to the analysis I mentioned on the population size and distribution of gay men in New South Wales. This work effectively started in 2018, and it culminated in a paper that was published in the International Journal of Geographic Information Science, and this was led by Denton Callender. And what we effectively did was took data from the 2016 Australian census and looked at the number of male or female couples who said that they were cohabiting, and we assumed that that would mostly reflect gay men and lesbians. But then what we did was, for New South Wales, we looked at that data. So that the data developed by Denton and Garrett mainly had data with numbers per postcode, but also the proportion of adult males or females in that postcode that were gay or lesbian. So for New South Wales, for some of the analyses we're going to see in this presentation, we developed 3 categories of postcodes. So low concentration was where fewer than 5% of adult males in that postcode were estimated to be gay. Medium was 5 to 19.9%, and high concentration was where over 20% of adult males were estimated to be gay. What we estimated in terms of the total number of gay men in New South Wales was that almost 53,000 men were gay, and across those 3 categories, approximately half lived in the low concentration suburbs and about a quarter each in the medium and the high concentration suburbs. In terms of how that looks on a map of Sydney or New South Wales, we see that the inner east and the inner west are the highest concentration suburbs, so over 20%, and a little further east, a little further west and North Sydney were the median concentration suburbs, and basically the rest of New South Wales are low concentration suburbs. So we then looked at data, and these data are from 2013 to 2019, so spanning both of the first and the second strategy. But what we saw was that in the top line there, the low concentration suburbs, there was effectively no change, but really a very small increase in the total number of HIV diagnoses. And in both of the medium and high concentration suburbs, there were quite substantial declines in diagnoses. But one thing that we realised we could do with these data, which has never been possible really in Australia before, because we haven't had good denominator data in terms of the number of gay men, was we realised we could develop rates of new diagnoses and look at these by suburb category. And usually rates of HIV notifications are reported per 100,000 people of the total population, but we wanted to do it by gay men. So just in terms of bisexual men, we don't think that these data, the population data, really reflect bisexual men, but in HIV notifications in New South Wales, bisexual men usually make up about 10% of notifications among MSM. So the data are mostly about gay men. And these are the results. And when we saw these, we thought this was really extraordinary, because the red line, which is the rate of notifications per 1,000 men in the high concentration suburbs, so over 20%, that went from having the highest rate to effectively, there was a small decrease which we think was based on increase in HIV testing and HIV treatment uptake among people diagnosed with HIV. But then a really remarkable change happened from 2016 onwards, effectively coinciding with the upscaling of PrEP in New South Wales, and large numbers of gay and bisexual men starting to use PrEP. And that line completely inverted, so that men in the highest concentration suburbs went from having effectively the highest risk of HIV to the lowest risk. And this was something that we hadn't really recognised before, and I think are really striking. Men in the medium concentration suburbs, in that light blue line, also had a significant decrease, a 36% decrease. But similar with the data I showed earlier on the total number of diagnoses, there was a small percent increase in the rate of HIV notifications among men in the low concentration suburbs. So this will get picked up by Cherie later, but yeah, that was really interesting data that we had never been able to do before. So now I'm going to be talking about trends in prevention indicators. What we did was, one of the things we did annually in the NHPPP was to hold an annual scientific meeting towards the end of the calendar year, and we would use that to review all of the surveillance and other monitoring and evaluation data that we had collected and analysed that year. And in 2019, because we knew we were drawing towards the end of the project and the end of the HIV strategy, which was from 2016 to 2020, we did a really major analysis of trends in notifications and prevention indicators. And we published that last year in this report, which is on the Kirby website if anyone wants to have a look. Andrew's the first author there. And there were many people involved in the development of that report, and this basically drew on data from the 2019 scientific meeting. And what I'm going to be showing in the next section are analyses from that are drawn directly from that report. And I just wanted to go over the data that I'll be talking about. So there are three sources. Firstly, data from the Notifiable Conditions Information Management System run by Health Protection New South Wales. HIV is, of course, a notifiable condition in New South Wales. So the Health Protection maintain an HIV registry. We'll also be looking at data from the Sydney Gay Community Periodic Surveys run by the Centre for Social Research in Health, and also data from the Access Network, which is run by the Kirby Institute and the Burnett Institute. And Access is a sentinel surveillance network that collects data from a number of clinics, sexual health clinics and private GP clinics in New South Wales and in other states and territories in Australia. So I'm going to run through some data on testing, treatment, and then PrEP. So first of all, looking at testing among high-risk men, which in the periodics, the gay community periodics are defined as any men who reported any condomless anal intercourse with casual partners in the previous 6 months. We looked at HIV testing among high-risk men in the previous 12 months by region of birth. And what we saw is that from 2016 to 2019, there was a slight increase in testing over the period, but there was effectively little variation by region of birth. But when we looked at it by gay postcode category, so again, high-risk men testing in the previous 12 months, there was a slightly lower uptake of HIV testing among men living in the low concentration suburbs. And we think that this really reflects men who are quite attached to gay community. That's effectively the sample in the Gay Community Periodic Survey. Some data I'm going to show later about diagnoses among overseas born men, I think seem to be a little bit at odds with this, because I guess what we saw in the previous slide was, there's high testing by region of birth, but we think that many men who are overseas born and not very attached to gay community are not really captured in the Gay Community Periodic Survey, and there are efforts underway to diversify the sample in that survey to better capture men who are recently arrived and not connected to gay community. So Then looking at testing by age, there was again a slight increase among most age groups, but lower testing rates among men who are aged under 25 and over 55. But one thing that is a really good news story is that in terms of HIV treatment among HIV positive gay and bisexual men by region of birth is that once people are diagnosed and connected to care, they have very similar treatment rates regardless of region or country of birth. So very little difference between Australian born and overseas born men. And that's I'm not showing it, but the data is the same for the proportion of positive men with undetectable viral load, but also very similar treatment rates by suburb category. So again, once people are connected to care, people treat at the same sort of rate. Now looking at PrEP use among high-risk men, PrEP use in the previous 6 months, again, there was little difference by region of birth, but remembering this is a highly gay community attached sample. What we did see though, but when we looked at these data by suburb category, was a really significantly lower uptake of PrEP among gay men in the low concentration suburbs. So a 20% difference in PrEP uptake from the men in the most gay suburbs to the least gay suburbs. And again, looking at by age, like testing, there was lower PrEP use among men who are aged under 25 and over 55. So I'm now going to I guess we just saw the prevention indicators. So I guess in terms of what effect that might have had on notifications, I'm now going to be reviewing some data from the notifiable conditions data at Health Protection. And although I'm going to be showing slides which have data including the 2014 year, you'll see on the right-hand side of the slide, I've made some summary points with the increase or decrease, and that is calculated on the period from 2015 to 2019, which is what we looked at in the trends report and the project. So there was overall a decline of 19% in new diagnoses between 2015 and 2019. But when we looked at that separately for overseas born men and Australian born men, what we saw is a much larger decline of 41% in new diagnoses among Australian born men and only a small decline overall of 6% among overseas born men. But then when we looked at overseas born men by the time since arrival in Australia, we saw that there was actually an increase of 10% between 2015 and 2019 in overseas born men who'd been in Australia for 4 years or less. So in summary, we saw declines in HIV diagnoses in the most gay suburbs, but not other suburbs. Lower testing rates among men in the less gay suburbs. High treatment rates among men in all groups, and again, this reflects that once people are connected to care, there's very little difference in the outcomes. And we saw from the periodic data lower PrEP uptake in less gay suburbs and men aged under 25 and over 55. And as I said, there are efforts underway to diversify the gay community periodic survey sample. We believe that among overseas born who are less connected to gay community, that there is lower PrEP uptake. It doesn't look different by region of birth in the periodic data, but we think if that sample was broader, it would look different. And then we saw declines among Australian born men, especially in the gay suburbs, but increases among recently arrived overseas born men. So finally, I'm going to be just presenting a few points on from an evidence brief that we prepared to help inform the consultations on some research in relation to HIV stigma and stigma in relation to same-sex attraction and gender. Effectively, and people with HIV. So effectively, there's been a lot of research in this area, but I'm just going to summarise some of it. So among people living with HIV, anticipation and experience of stigma from healthcare workers has been found to lead to both lower trust in clinicians, lower quality of life, and poor adherence to antiretroviral therapy. There was, in the last couple of years, there's been some interesting qualitative research among recently arrived Asian-born gay and bisexual men in Australia. And this has been conducted both in Victoria by Phillips and colleagues, and in New South Wales by Stephen Philpott here at the Kirby Institute. And they found that perceptions of HIV-related stigma do contribute to anxieties about HIV testing among recently arrived Asian-born gay and bisexual men. Just in terms of gender and same-sex attraction, the Private Lives study, which ran in 2011 in Australia, found that trans men and trans women reported the highest levels of heterosexist harassment or abuse in the previous 12 months, but high proportions of gay men, a third of gay men also reported abuse in the previous 12 months, and these experiences were associated with poorer mental health. So I just wanted to acknowledge the many, many people who are involved in the NHPP, and the project is continuing now in a way that we might talk about later, but this reflects the people who are involved in the project up to 2020. And finally, I would just like to thank Stephen Negros. Stephen conducted the analyses of HIV notifications data. Curtis Chan conducted the analyses of the Sydney Gay Community periodic data. Preetal Patel conducted the analyses of access network data, and Ben and Andrew helped in putting this presentation together. So thank you everyone for joining.
Okay, thank you very much, Philip. I think that was a great overview of the progress that's been made in HIV prevention in New South Wales over the last 5 years, but also really does highlight some of those areas where we have major challenges remaining, particularly in MSM outside of the gay Sydney suburbs, in the overseas born and the young. I think this next presentation on strategy will really highlight where we're going to try to address those issues. Cherie Power is a senior policy analyst in the Centre for Population Health, New South Wales Ministry of Health. She holds a master's degree in public health from the University of New South Wales. She was the lead author and project manager for the development of the latest HIV strategy 21-25, encompassing prevention, PrEP, testing, treatment and stigma. And she was a key partner investigator in the partnership grant that Philip has talked about. Over to you, Cherie.
So I'd also like to acknowledge the Cammeraygal people of the Eora Nation and pay my respects to their elders past, present and emerging. Today I'll be talking about the development of the HIV Strategy 2021-2025 and how we worked with the NHPP project to use policy relevant research to inform the content of the strategy. Today I'll talk about how collaboration is key in developing that policy relevant research, how the HIV strategy was developed in partnership, what the focus of the strategy is, their headline target to achieve virtual elimination of HIV transmission, priority populations, goals and targets, initiatives, and a bit more about the NHPP project, and some principles of research policy collaboration. So conducting research that can be used to improve government policy can be a challenge for all of us policymakers and researchers, and obviously the key is collaboration. For instance, the landscape for HIV over the last 5 years has changed. With scientific breakthroughs, PrEP is a big one. So policymakers, had a problem to solve how to implement these breakthroughs, in order to make them more accessible to communities that need them as quickly as possible. So EPIC New South Wales was one of the largest PrEP implementation trials globally, and this was a significant collaboration between the Kirby and the Ministry and multiple partners. It exemplifies a strategic approach to the scale-up of evidence-based interventions and how rapid implementation across services can be achieved through a strong partnership between, for instance, system managers, clinical services and researchers. And the EPIC New South Wales trial led to substantial service redesign and mobilisation of the health system, within existing resources, and prepared us for the transition of PrEP under the Pharmaceutical Benefit Scheme. So the strategy was developed in partnership, of course, with clinicians, GPs, researchers and affected communities. And the NHPPP project was integral to this development process. The evidence that Phillip just presented was delivered by the project at the right time to allow me to frame the problem for stakeholders, completing the written submissions. The evidence set the scene at consultation workshops to allow our stakeholders and communities to have the right conversations and tell us, what interventions should be prioritised over the next 5 years. At workshops, we could build on what the evidence was telling us about current access to prevention, testing and treatment, and those subpopulations who were not benefiting from recent progress. The NHPPP project also provided valuable feedback, infrastructure to the strategy, which was particularly valuable to me personally, because we really had to develop that strategy on time in the year of COVID, when most of our staff and resources were diverted. So I asked Phillip to lead the development of several evidence papers in collaboration with his research colleagues and Andrew and the ministry to inform working group meetings and stakeholder workshops and the strategy itself. And the NHPPP project working groups provided feedback on the draft targets for the strategy to ensure that they were measurable, meaningful and valuable. The project's evidence and trends reports allowed us to solve the key policy problem or question: what should the next 5-year strategy identify as priority interventions, priority populations, and how should we measure this progress? So the new strategy builds on the momentum of the previous two, and as we've shown, we have a renewed focus on subpopulations who have not benefited from the same level of progress. To make new gains, we've got to focus on stigma and discrimination, piloting and implementing new technologies like telehealth, focusing on, we're focused on eliminating our preventable infections acquired in New South Wales, and then connecting overseas-born people who acquired HIV abroad into testing and care soon after arrival in Australia. And these objectives came from the evidence. The strategy introduces a new headline target to achieve a 90% reduction in the rate of preventable HIV infection in Australia, or New South Wales in this case, as an ambitious target of virtual elimination. We've been working with the NHPPP project to define preventable infections, in a consistent way, and we'll continue to discuss how we present this new indicator with them. The current definition is that infection is preventable in Australia if the person is Australian born, including people who acquire HIV on short-term travel overseas, overseas born people in Australia for more than 4 years, and overseas born people in Australia for 4 years or less, but excluding those with late HIV diagnosis. Page 5 shows a snapshot of the aims, goals, targets and initiatives. We'll normalise HIV testing, encourage access to prevention, ensure early treatment and reduce stigma and discrimination. The NHPPP project trends reports that Phillip outlined today allowed me to develop a commentary in the strategy, about the need for renewed focus on populations not benefiting from recent success, including MSM living in outer Sydney and regional New South Wales with lower concentrations of gay identified men, overseas born men recently arrived 4 years or less, and MSM under 25 years. The trends reports allow the strategy to focus on delivering culturally tailored models and strategies for cold and overseas born MSM less than 25 and in areas of lower concentrations of gay identified men. So the key prevention target in the strategy is to achieve 90% prevention coverage, or we mean, at least one form of HIV prevention for MSM with casual partners. We developed this. We also developed like this key prevention target with the NHPPP and stakeholders, and defined it based on the current data, which is provided by Martin Holt's team at the Centre for Social Research and Health in the Sydney Gay Periodic Survey, which Phillip showed us. So we also ambitiously aim for a 90% PrEP coverage for MSM without a condom, which will also be measured through the Sydney Gay Community Periodic Survey and the New South Wales minimum data set in clinics. In terms of testing targets, we use the cascade data analysis by the Kirby to monitor the UNAIDS target of 95% of people living with HIV are diagnosed. In New South Wales, only 91% of people living with HIV in New South Wales are diagnosed. And because of this trends data from the NHPPP, we're able to develop evidence-informed initiatives to respond to this shortfall in a targeted way and an efficient way to those who most need it. Under the new strategy, we'll reduce this undiagnosed population by expanding innovative testing models such as peer-based testing, self-testing, community-based testing in more sites in outer Sydney and regional New South Wales. So stigma and discrimination, Phillip outlined some of the evidence for us. Stigma can be connected with living with HIV, sexual behaviours, gender identity, sex work and drug use. So to make new gains, the strategy will reduce stigma and discrimination as a barrier to prevention, testing and treatment. And the background to this new chapter for New South Wales and the targets on stigma really relied on the work underway by the Stigma Indicators Monitoring Project by the Centre for Social Research and Health. Carla Trelaw at the centre, called me to gauge interest in some viral hepatitis indicators for New South Wales under the project. And it got me thinking, and I called her a month later just to see what's available for HIV in the Stigma Indicators Project. So, thereafter had a conversation with her team, and then we became, quite confident about introducing what was a new chapter for New South Wales in stigma. And then, we asked Phillip to create a stigma stream in the NHPPP working groups in the strategy development process, and we developed the evidence brief, and that was discussed at working group meetings and the workshops, etc. So from the evidence, we were able to focus the prevention and testing initiatives to deliver outcomes and better value for money. The strategy aims to increase the number and coverage of PrEP prescribers, including increasing access for cold, overseas born, MSM and young men, and in areas with lower concentrations of gay identified men. The statewide HIV testing campaign, shown in red there on screen, is designed based on the data, of course, and targets non-gay identifying MSM in outer Sydney and regional with a cold focus. The dried blood spot testing pilot, is a key initiative that continues under this strategy. And, it's a great example of a key collaboration between researchers and policymakers to make technologies available faster, through an implementation pilot under a research framework. The DBS or dry blood spot testing pilot began in 2016, to increase testing options for people that experience barriers to conventional testing. We're currently aiming, the next step will be TGA approval. It's an off-label at the moment, finger stick test for HIV and Hep C. It's a collaboration between lab, clinical, policy, local health districts, NGOs, and it really showed sort of, the flexibility implementation. It enabled a responsiveness in the design to address barriers to testing through making decisions such as, data collected from participants has been reduced, by agreement by the pilot investigators and policy leads. We've reduced the data collected to increase access and minimise burden on services and individuals to access the testing, so they don't need to complete, loads of forms. Reduce that back. We get less data, but we get more testing. And, it really shows sort of the real world decisions that we make as a collaboration for better outcomes. So the outcomes of the project will facilitate, our achievement of this headline target. The project, or the NHPPP project, will provide a program of monitoring and evaluation and, as Phillip said, rapid feedback system to guide implementation. It'll perform implementation research and, we report how exemplary really this project has been for us. It's a really great model to kind of bring us together constantly or regularly with the working group meetings and interpret data, real-time feedback to guide policy. And, it allows us to tweak our interventions and the New South Wales population health response to testing, prevention and treatment. So just to, conclude some of our principles for research policy collaboration, partnerships such as this project facilitate the co-design of research where, researchers and policymakers are involved in all stages of research process. We have, pragmatic data collection trade-offs that we manage, such as what I described in the dry blood spot testing in EPIC New South Wales. So the trade-offs between the traditional research perspective of wanting to collect significant amounts of data versus what is feasible within implementation and scale up in the real world, and what data is essential to inform the service redesign and fill evidence gaps. It's important to recognise that research questions can evolve as policy and regulatory landscape change, and research needs to be agile. Incomplete research can inform policy decisions. Extensive research that is impractical in the real world is very limited in its impact on policy. So policymakers, also need to acknowledge there might be a cost for researchers not completing everything, and, to be aware of the importance of publications for researchers. The exchange of value needs to be shared by both parties in this collaboration. The importance of translatable research, embedding research as part of the program implementation rather than a parallel process. And if implementation research is the goal, we need collaboration and to identify shared interests. Thanks. Thanks, Andrew.
Great, thanks Cherie for that excellent presentation, and I'd really like to thank and acknowledge the really long-term commitment that New South Wales Health has had in this policy space. We really take it for granted in New South Wales that we work with a senior policy partner that is committed to the elimination of HIV, and we're making great strides in New South Wales. We shouldn't, it's easy when we just have an audience of New South Welsh people to forget that these reductions in HIV that we're seeing are amongst the largest that we're seeing anywhere in the world. And this degree of analysis highlighting where we need to do better, I think, has a degree of sophistication that you rarely see. And it wouldn't really have been possible without the central leadership of New South Wales Health, but also the central involvement of community-based organisations like ACON and Positive Life, who were both absolutely central to the conduct of this research, as was the participation of ASHM, the peak professional organisation in our field. And it's no surprise that because of all of that, the rate of success of NHMRC Partnership grants at the Kirby Institute is probably higher than any other institute in Australia, because we have such a long history of collaborative research with government, with community and with professional organisations that seems to be working really well. I do encourage people to ask questions in the Q&A field. We do currently only have one comment there, which I think is a comment for Phillip, really, and I'll just quickly summarise it. This is a comment from Martin Holt from the National Centre in the Centre for Social Research in Health, who noted that there is a hint in the gay community periodic survey data that perhaps testing for Asian-born gay and bisexual men started a bit lower and caught up during the strategy. So perhaps there was a bit of a change there. And Martin speculates that difference with lower testing rates is likely to be more pronounced in recently arrived gay and bisexual men. I'll just make a note, given it's Martin Holt who's made that comment, that Martin is leading a new partnership grant, which is aiming to greatly expand the behavioural surveillance for these issues in these underserved populations, and recently arrived overseas men being one of them. Phillip, did you have anything you wanted to add to that?
No, thanks Martin for pointing that out, but I don't think anything to add.
Okay, Phillip, I think there is another question for you from Richard Gray there. Did you look at trend in CD4 or late diagnoses by by the suburb categories or by region of birth?
We did, and just in getting ready for the presentation today, I had too many slides and I had to take those out, unfortunately, but there were in fact some very interesting patterns. So what we saw in terms of late diagnoses was really very significant declines in late diagnoses, particularly among Australian-born men in the most gay suburbs, so that now there are almost no late diagnoses among Australian-born men in the most gay suburbs, but there was no change in the least gay suburbs, and among men in the medium category of gay suburbs, there was, I can't remember now if it was a small increase or not much change, but when we looked more closely, we saw that most of the late diagnoses in the medium gay suburbs are actually among overseas-born men. And because those men often live close to universities, which are, in the medium gay suburbs. So there are some very interesting patterns in terms of late diagnoses. Some data that I also didn't show was that the late diagnoses among overseas-born men are mainly driven by men who've been here for 4 years or less. And that's why the priority that Cherie outlined in the strategy of earlier diagnosis among overseas-born men is really important. We believe that many overseas-born men who are diagnosed late in New South Wales actually arrive in New South Wales already having acquired HIV, and many of them are in fact diagnosed on their first ever HIV test. And something that one of our working group chairs, Angie Pinto, has noted from her work in RPA, Royal Prince Alfred Hospital, is that, and this is really extraordinary in this time and age, is that those men are getting diagnosed literally at death's door, turning up in the emergency department very, very ill with AIDS. And that's really quite shocking, I think, in this day.
Great, thanks, Phillip. I don't see any other questions there at the moment, so I might just pick up on some of Cherie's presentation. Cherie, I think you gave a great presentation of some of the difficulties and the successes in implementation research done in partnership with researchers from the Department of Health's point of view. And I can certainly say from experience here at the Kirby in running the EPIC New South Wales study, that was a very rapid learning curve for us in the ministry wanting rapid information on take up of PrEP, we academics wanting and needing publications from that so that our careers were helped rather than hindered by doing such research. Do you have any reflections on how that PrEP project ran, or how you might see implementation projects for some of the new PrEP agents that are coming online, such as injectable PrEP, which will probably be being introduced within the next couple of years?
That Epic New South Wales certainly has set us up, a really great precedent to look at those new injectables coming online. And I know some of your team are working on some models to put forward for consideration. I also wanted to pick up on your point that, the workshops and all the work really relies on those community partners and picking up on, misdiagnosis, in particularly the cold group. We've got a lot of work that's underway, including by ACON. They just did a PrEP campaign attached to Mardi Gras. They're doing the Chinese A-test clinic, the peer-led model with those, those speakers that can speak the language. And also, we're seeing in those A-test community clinics that men are travelling in from Western suburbs to, have those tests in a confidential way. So we really want to work on expanding those peer-led models to outer Sydney, etc., and our, online testing DBS, and our rapid testing models, that is a rapid testing model. And the international students website has been launched as well. So we're really trying to make it easier for international students to get the information quicker and all in one spot, so it's not so overwhelming. So we're just sort of slowly, working with ED departments to tighten up those links with the public health, so like units in the HSP program, so they don't need to give the diagnosis for HIV. The public health units will do that work for them. They just need to test clients or patients coming into the ED, etc.
Thanks for that, Cherie. I think, you outline what are a number of very significant challenges for us because, as Phillip's data showed, we've done tremendously well with the community who traditionally had the highest rates of HIV. And the rates in those groups are now approaching, well, they're 2 to 3 per thousand at the moment in the inner city, and UNAIDS has an informal definition of 1 in 1,000 as being elimination. So it's not far away. But these new groups who are culturally and linguistically diverse, they're some of them are young, some of them live a long way from the centre of Sydney, and one area which we did have trouble in our analyses getting to the heart of was how many of these men don't identify as gay and might be bisexual men. And I think all of those are real challenges for us to move into working with those communities. I don't see any new comments there. Are there any final comments? So please, if you do have a question, if you've been on the edge of asking one, please ask it now. I see there's still nearly 60 attendees, so if your last chance to ask a question is now. While I just asked Phillip and Cherie if they had any closing remarks they wish to make.
I'll go first. Well, thanks, Andrew. Nothing in particular. I think just to note, I guess as Cherie pointed out, I think it was a really valuable process for us as researchers involved in the project to work so closely with the ministry on the development of a new strategy. That's a really gratifying thing, and I think for us, as researchers, really great to be able to see that our research was directly informing something and so rapidly. I think it's unusual for a lot of researchers to be in that position, and I think it shows that in the way that Cherie talked about, in terms of the increasing focus on implementation research and translation of research into practice. I guess we not only have a good track record in New South Wales through the enthusiastic collaboration that is made possible through the enthusiastic collaboration of all of the partners of the key agencies involved in HIV prevention in New South Wales. So it's a great environment to be working in.
Thanks, Phillip. Cherie, before we ask you for final comments, my plea did flush out one question from Jonathan King, and he's asked whether there's been much engagement with communities born in South and Central America who do very much show up in the HIV surveillance data in New South Wales. Cherie, did you want to comment on that?
South and Central America, yeah?
Yeah.
Yeah. So yeah, Phillip can also talk about this. We do monitor HIV transmission by country of birth, by clinic. So we know where they're presenting. We know which doctor would have diagnosed them. So we absolutely are working with all cold groups. The Multicultural HIV and Hepatitis Service absolutely works with all cold groups. So luckily for me, the community organisations are the people that are most appropriate to work with these communities. We sit here and try to design communication campaigns to get them to the right services. But ultimately, it's the radio, it's whatever mechanism is talking to that particular community, and we look to the data. So if they're showing up in the data, we will start focusing on their channels that they prefer, etc.
Thanks, Cherie. Phillip, did you want to make any comment?
Yeah, perhaps just one thing to add, which is that the ATEST Rapid HIV Testing Service, which is a peer-led, community-based rapid testing service led by ACON with partners, sexual health clinic partners, Sydney Sexual Health, Kirkton Road, and RPA Sexual Health as their clinical partners. That service has put a lot of effort into working with South and Central American gay and bisexual men and Asian-born men. So there are peer testers who work in the ATEST services who speak Spanish and Mandarin, and a high proportion of the clients at those services, the ATEST services, are men from South and Central America and Asian-born men. So those services have been very successful in attracting those men to free rapid testing. And there's a great evaluation report on those services, which was led by Curtis Chan and Ben Bavington. And one of the really interesting things I think that report showed is that although the service, I think, does a little over 1% of the total number of HIV tests conducted in New South Wales, it diagnoses about 13%, I think, of the total number of diagnoses, I think, among either all diagnoses or diagnoses among gay and bisexual men, who are most of the diagnoses. So yeah, there have been particular efforts by ACON and its partners in that area.
Thank you, Phillip. Cherie, any closing comments that you wish to make?
I just reiterate, it's a real joy to work with, the infrastructure of the NHPPP and the associated community partners. It really is a partnership, and I really thank you and our community partners that are online as well, and also Health Protection New South Wales that provides all the data and expertise as well.
Great.
So we're looking, we want to increase testing come out of COVID. We're still coming out of COVID and trying to get people to keep testing. So DBS, for example, the online testing has shown, a lot of recovery, and as has PrEP. So we want to keep going to, make sure PrEP and testing increases again post-COVID.
Great, thanks, Cherie. And it's worth me noting that we have put in an application for a new 5-year partnership grant, which we hope will be funded from next year, to allow us to continue the monitoring and evaluation as we head towards those elimination targets, which, if we do reach that target of a 90% reduction of preventable HIV by 2025, we will be the first place in the world to meet the UNAIDS definition of elimination, which would be extraordinary, obviously. So just to finish, a big thank you to both Cherie and Phillip for their great presentations today, and thank you to all the attendees for attending today. Thanks very much, and bye.
See you later, everyone.
Bye.